كل الموجودين وإن شاء الله تبقى التوك خفيفة عليكم. Today I'm going to talk about therapeutic plasma exchange in TTP. First, plasmapheresis means to take away by force. It's taken from the Greek word apheresis and from the Roman word apheresis. TTP, or thrombotic thrombocytopenic purpura, is a rare disorder. It affects 1% per 300,000 individuals in the United States, with a very high mortality rate exceeding 90% of untreated, while with treatment the mortality rate decreased to less than 10%. We have two types of TTP: congenital type, in which there is deficiency of the protease enzyme, and primary TTP, in which there is O2 antibody to the metalloprotease. This metalloprotease is named ADAM-TS13, a shortage for disintegrin and metalloprotease with thrombospondin 1-like domains member 13. The normal function of the ADAM-TS13 is the cleavage of the large polymer Wolver-Brand factor. That's what normally happens. But in TTP, in which there is deficiency of autoantibodies, there is failure of that cleaving, and there is large or multimer Wolver-Brand factor, which aggregates multiple platelets, leading to thrombotic manifestations, especially at the high share sites, mainly the CNS, the kidney, and the heart. So why do some people get TTP? There is autoimmune hypothesis in the form of inhibitors to ADAM-TS13, which might be idiopathic or drug-related. Also hereditary conditions as Shulman-Ashab syndrome, and other associations like with pregnancy, infection, cardiovascular, and other surgeries. To diagnose TTP, first we needed a bin test of microangiopathic hemolytic anemia, in which the COMS test is negative, thrombocytopenia with platelet count less than 100,000 cells per cubic millimeter, CNS abnormalities in the form of headache, confusion, focal deficit, seizures, and even coma, renal involvement, and fever with temperature exceeding 38 degrees centigrade. But because of the importance of early diagnosis and early management in decreasing the mortality in TTP, the revised diagnostic criteria recommended that TTP should be suspected in the presence of microangiopathic hemolytic anemia and thrombocytopenia alone. This is one of our patients diagnosed to have TTP, and we can see the pallor in his palm in comparison to mine. Jaundice in the sclera due to hemolysis, ecchymosis due to bleeding and thrombocytopenia. This is during the session of the plasmapheresis. And this is the plasma of the patient, and we can see the dark color due to hemolysis. So to diagnose TTP, we need first CBC, in which we will find microangiopathic hemolytic anemia manifested by decreased hemoglobin, decreased hematocrit, increased red cell distribution width, thrombocytopenia, and on the peripheral blood smear we will find schistocytes or fragmented RBCs. As for the chemistry, the LDH and the indirect bilirubin will be increased as a manifestation of hemolysis. We need to assess the activity level and the inhibitors of ADAM-TS13, which is helpful in the diagnosis, but treatment should be started at once without waiting for the results. So, when we suspect the ADAM-TS13 should be asked for, as well, the next exchange results are withdrawn after passage of 3 to 4 hours after the exchange. This is blood film from a patient with TTP. This is before the plasma exchange. We can see numerous schistocytes or fragmented RBCs. This is the same patient after the exchange, showing marked decrease of the fragmented RBCs. As for the response, some TTP patients recover without further treatment, while others relapse and require further therapy, including immunosuppressant, steroids, or rituximab. For the steroids, randomized controlled trials compared high-dose versus low-dose steroids, and it concluded that high dose are more effective than the standard dose. The high dose is given in the form of 10 mg per kg per day for 3 days, and then reduced to 2.5 mg per kg per day. Another trial was done on 40 patients with acute TTP. They were given 375 mg per meter square of rituximab for 4 weeks. And the trial concluded that the rituximab reduced the relapse rate, reduced the number of the exchange runs, and it should be used in all patients with severe TTP with end organ dysfunction, particularly neural and cardiac dysfunction. As for the cyclophosphamide, the literature is sparse. There is no randomized controlled trials, but the expert opinion suggests use it in patients who are not responsive to the plasma exchange, steroids, or rituximab. And this is the new hope, or the new light in the darkness, the new drugs. Eculizumab, which is terminal complement C5 monoclonal antibodies, anti-F13 antibodies, which is a molecule that prevents the interaction of platelets with voloclan factors, so no more thrombosis formation. And there are clinical trials ongoing on the recombinant anti-F13. This will be very helpful for congenital TTP. So after this jam, we can take home our message that untreated الناحية الثانية بتزحمة شوية. نجاوب ideas, نجاوب traffic. Untreated TTP mortality is high, exceeding 90% if less untreated, which can be reduced with prompt plasma exchange. The revised diagnostic criteria stated that TTP must be considered in the absence, in the presence of thrombocytopenia and microangiopathic hemolytic anemia alone. In TTP, plasma exchange must be considered even if the patient is extremely sick and unstable. Finally, I would like to express my appreciation to everybody help providing this great. Thank you very much.